Thank you for joining our afternoon section on medical topics and public health. My name is Daniel DeFeo. Before we hold the applause, please. Before we begin, I would like to remind you that in order to receive CMA credits, you must complete the survey that is located in the NJOBS app. If you click on each lecture title on the schedule and scroll to the bottom, you'll see the survey link. If today is the only day you'll be at the conference, please remember to fill out your digital attestation form. We ask that you only fill out the form when you're leaving the conference, as you cannot edit your answers. There will be no official coffee break during the afternoon section. If time allows, I will give time breaks. But if the coffee will be available in the back of the room, so feel free to quietly get a cup. And then please remember to silence your cell phones and place them on vibrate.
Keep it off.
I'm honored to introduce our first speaker today, Dr. Michael Guma. Now you can applause. Dr. Guma graduated from Wake Forest University in 1984 with a bachelor's in biology. He attended the Kirksville College of Osteopathic Medicine in Kirksville, Missouri, aka Mecca, where he received his osteopathic medical doctorate degree in 1989. Dr. Guma then returned to New Jersey to do his residency in internal medicine and subspecialty training in rheumatology at St. Michael's Medical Center in Newark, New Jersey, which is now part of Seton Hall University's School of Graduate Medical Education. Dr. Guma is board certified in both internal medicine and rheumatology. Dr. Guma is presently the director of rheumatology at St. Michael's Medical Center. In July of 2015, he became the assistant program director for the St. Michael's Medical Center New York College of Internal Medicine residency program. He's also served as an assistant professor of clinical medicine at Seton Hall, University's graduate of School of Medical Education. He is also director of osteopathic medical education at St. Michael's Medical Center. He holds a faculty position at the University of New England's College of Osteopathic Medicine, where he is an associate professor of clinical medicine. Along with the many awards Dr. Guma has received along the years, he is also a co-founder and vice president of the Guma Family Foundation, which is a nonprofit charity which has given over $100,000 to Tomorrow's Children's Fund of Hackensack University Medical Center, and thousands to families of children with brain tumors. Please help me welcome Dr. Michael Guma.
Thanks. Nice intro. Thank you. Hi, everybody. So I thought that I would pick a topic that hopefully is relevant in some way to everybody. Forgot I don't have to use that, which is good. So I chose rheumatoid arthritis as a topic to do today. What I want to do is I want to give us a good overview of where rheumatoid arthritis is in terms of making the diagnosis, in terms of really the newer things that we think cause it and what triggers it. And there's some good information out there that's relatively new. And then our treatment options. Now, if you're primary care or a different specialty, you're never expected to be the one to decide, do I add this drug to methotrexate? Which biologic do I use? That's not in this purview. But what you should know is, why we make these decisions, how they work. What are the things about this medicine that you need to be aware of? Because for the primary care, if you're the front line, you're like the Marines, you're in first, right? So you're seeing the patient for other things. You have to know, or not, it's going to help you to know things about that patient when they come in with chest pain and they have RA. When they come in with a UTI or sinusitis that requires a medication, an antibiotic that might interact and send one of our other medicines into the toxic range. So I thought we would do that, go over that. And then I want to save some time at the end to just answer any questions you have about RA or, quite honestly, any other rheumatic disease. I welcome those questions as well. So learning objectives, understanding what contributes to the development of RA, look at the clinical manifestations, discuss the treatment options, what are the expectations at the primary care level, and let's cover some of the challenges that we face. You really should start with RA. You talk about the epidemiology. It's really a lot more common than you think. Some of the numbers estimate as high as 1% of the population has rheumatoid arthritis. So if you have 330 million Americans, you're talking about 3.3 million people with RA. Some other studies say the prevalence might be a little lower, and I'll tell you that it varies among populations. If you look at rural Africans, the prevalence is about 0.1. If you look at Native Americans, the prevalence may go as high as 5 or 6%. It's a lot of people when you think that when you realize the average cost of some of these biologics is between $80,000 and $100,000 a year. So the system really can get taxed financially. The incidence is about 40 per 100,000. And the other thing about RA is that it's like many of our other autoimmune diseases, it's more common in women than men. And the average age is about 40. I think one of the really important slides is this one already. And that is that it's really not just a joint disease. So we think about RA, we think about, another patient with swollen, painful joints, right? But there's a lot of other things involved here in these patients. For example, one of the greatest causes of death in RA is cardiovascular disease. So they die of heart disease a lot more than people in the general population. In fact, a lot of people put rheumatoid arthritis very close to the major risk factors of cardiac disease. So if I have somebody who's hypertensive, diabetic, family history, smoker, I'm worried about cardiovascular disease. If they have RA, I'm also worried about cardiovascular disease. So my advice would be, if you're questioning something, pull the trigger a little bit faster on the patient with RA. They have a greater risk of serious infections. RA can do it. We know they have a dysfunctional immune system. I think you could blame some of that stuff on us and our medications that we use, but nonetheless, the risk is higher, especially if they have other comorbid conditions or they have extra-articular disease. They have a greater risk of malignancy. Most rheumatic diseases across the board that are inflammatory have a greater risk of malignancy. In particular, we see a greater risk of lymphoma, and in particular, they are non-Hodgkin's lymphoma. And that's very true in people with RA. So a lymph node in a patient with RA has to be taken very seriously unless you have a known etiology for it. And a lot of times it's challenging for us because you see a CAT scan and there's scattered lymphadenopathy on a CAT scan and they have RA and you're like, well, I think this is from the RA, but it could be from something else, something more sinister, could be lymphoma, and we take those seriously and we look. And when in doubt, I always say if you have a lymph node you can't explain in one of our patients, when in doubt, take it out. Just get it taken out. Be safe about it. Pulmonary disease is significant in people that have extra articular manifestations. This is especially true for the patients that have high rheumatoid factors or high CCPs. And we'll talk about that in a minute. But this is very difficult to treat for us as rheumatologists when they have bad interstitial lung disease. And there's a whole myriad of manifestations they can get, by the way, from upper airway involvement at the cricoarytenoid muscles down to the small airways, medium airways, nodules, pleural disease. So it's quite extensive, actually. And they do have a greater risk of GI bleeding. It's probably a little bit less with the use of COX-2 inhibitors, and the life expectancy goes down, especially if they're not treated appropriately. I think the one point I could make out of this slide is that everybody's worried about all the medications that people use in rheumatology. Oh, those drugs cause cancer, those drugs are bad, those drugs are bad. If we lower the inflammation and we treat the disease and we improve the targets that we shoot for, the patients actually have a lower risk of cancer. Their risk of heart disease goes down as well, by the way. So treating our patients aggressively, they have better outcomes overall, not only their joints. One of the things that rheumatology is known for are these expensive drugs. And if you look at our medications, they've climbed incredibly over the last 20 years. In 1998, when etanercept, which is Enbrel, came out, etanercept was $16,000 a year in 1998. Now etanercept is over $80,000 a year, right? Not available as a generic yet, soon to come, hopefully, because I think in England, they can get Humira, which is adalimumab, for $6,000 a year generic. But here in the US, because they won't let it come out yet, it's still over $80,000 a year. And look at the bottom right slide. Look at the cost of the rheumatoid drugs compared to the rest of the drugs out there. You get an appreciation as time goes on, going outward on the x-axis. As time goes on, look at the pink line, how it climbs a lot higher than the other drugs. It's really been a significantly greater percent change than the other medications. Genetics. If there are residents in here or students in here, I would say that there's one thing here I think worth knowing. And look, we all look at disease differently now, right? We all look at disease as a combination of a genetic predisposition and something in the environment that triggers it or worsens it, sets it off. And in the genetics here, there is a group of genes that we do have isolated, which when people have this group, they are at greater risk of developing RA. If they have RA, it's going to be more aggressive. And if they're smokers and they have RA, it's going to be very aggressive. And that's called the shared epitope. So if you're recertifying for boards in the next couple of years, you might want to know that. But if you're not, you can put that aside for now. And you look at this and you say, oh my God, what is he kidding me with this slide? I have to know this slide too, right? So I like this slide, and I'll tell you why. Because this is like in 15, 20, 30 seconds, you can get a good kind of overview of what we see in rheumatology. When you have the immune system, you have a cell that basically brings the antigen to the immune system, the antigen presenting cell. And the antigen presenting cell will join to the T cell, the CD4 cell, right? And you need two signals for that. The antigen presenting cell brings antigen, and then you have a second signal that has to be there. So I can do this on a pointer right there. The CD4 cell is like the quarterback. He takes the ball, he tells everybody else what to do. He tells the other T cells, you get activated against that antigen. He tells the B cells, you get activated against that antigen. Macrophages. And there's a whole big network, like a spider web. It's actually like a drunk spider web. When you look at all the lines, they're all over the place. But it's like a spider web of interactions. And you wind up with that B cell making rheumatoid factors. You wind up with the T cell activating other cells which create cytokines, inflammatory proteins, which really drive RA. And in particular, there's a couple of cytokines that are very important in rheumatoid arthritis. And you've heard the names, tumor necrosis factor, right? Etanercept, adalimumab, all the commercials that you see people dancing on TV because the drugs are so expensive, right? And then we have, right? Then we have interleukin-1, which is less popular, and interleukin-6, which those of you who do hospital medicine have a lot more experience with that than you did a few years ago, because interleukin-6 is one of the drugs they use in COVID for tocilizumab. So they have a lot of, there are three big bad boys that we like to target, and they activate other cells too. They make the bones thinner by activating the osteoclast. They thin the cartilage away and wear it away by degrading chondrocytes, and they cause a chronic inflammatory condition around the joint when the synovium gets thick and we develop a pannus. But where does rheumatoid start? So you say, how did I get this RA? People look at, they say, you diagnose somebody with RA in July of 2022, and the patient's going to say, what did I do last month to get this? What did I do in the spring to get this? What did I not eat? What did I take? Well, that process probably began 5, 10, maybe even 15 years before. And this is what we presently think is going on now. So if I ask you, where does RA begin? And I told you it begins in the mouth, or it begins in the lung, or it begins in the gut, you would look at me and say, Guma, you're out of your mind. There's no way it starts in those organs. But it does. At least is what we think. So we know that there are certain proteins in the body that when they're exposed to inflammatory conditions will undergo a process called citrullination. Arginine residues on this peptide get citrulinated to a citrulline residue. There are certain people that are genetically predisposed to thinking that that citrulline residue, which just happened because of inflammation, is now foreign. And you develop an immune response to that citrulline peptide. And we can actually measure that by measuring anti-cyclic citrulinated peptides. That's where your CCP comes from. So it's the whole process of citrullination which happens in inflammatory conditions. It's different in different organs, but it happens a lot in the mouth, and it happens a lot in the lung. So can you think of something in the environment that causes inflammatory mouth conditions and inflammatory lung conditions? Something that causes inflammation in those two areas, which can trigger that process of citrullination, and in the right person or the wrong person, set the process in motion. And that's smoking. So that's why they really believe that smoking is one of those conditions which can really trigger RA. There's also a lot of thought about the microbiome. You hear everybody talking about the microbiome now, that bacteria in our gut can have possibly some influence on disease and disease outcome. And I'll tell you that they've done really good studies that look at patients with lupus nephritis, and they go in their gut, and they find bacteria in that gut that is not present in the same amounts in people that don't have lupus nephritis. Cause, effect, not clear yet. That chapter has yet to be written, but there's definitely an association. So changes in the mouth and inflammation, changes in the lung, and maybe changes in the gut. One other thing about bacteria, if you look at the mouth has an organism called Porphyromonas gingivalis, P. gingivalis, and it's a bacteria that you see in a lot of people that have, it goes higher in people that have bad dentition. That actually is responsible for the citrullination. So P. gingivalis being the organism that does it. So really interesting to think that people who smoke might actually trigger their RA. Not 100% proven, but this is where the thought is going right now. The other thing is they've actually looked at military people in the military, not recruits, people in the military. And let's say a guy is 40 years old, and the guy develops RA. And they say, okay, this guy's 40, he's got rheumatoid, his rheumatoid factor is high, his CCP is high. You know what? We've got blood on him from when he joined 20 years ago. Let's go back and look at his blood. It's sitting in some cellar somewhere in like Oregon, right, in dry ice. So they take the blood out and they look for CCP antibodies. And they're positive. They're positive 10 years before in really low levels. And if you plot, let's say in the cases where they're lucky enough between the US and Europe to get serial blood samples every couple of years, you can actually see the CCP levels climb right to the point pre-RA, a year or two before the RA takes off, and then clinical disease starts. So the process probably begins a lot earlier than we think. The other thing about rheumatoid is that once you develop these antibodies to the citrullinated proteins 10 years earlier, and as they're ramping up, they will eventually spread to other proteins. So you'll develop a more diffuse immune response, the idiotype switching it'll undergo. And once it develops a significant enough immune response and enough cells get involved, then it ramps up. When it ramps up, it tends to go to the synovium because the antigens there are proteins that this immune response is geared to attack. And the rheumatoid synovium is different than a lot of the other synovitises that we see in rheumatology. It's inflammatory and it's destructive, significantly, intensely destructive. It digs into the bone, it digs into the cartilage, it makes the bone thinner, it makes more blood vessels grow, and it brings more inflammatory cells with it. Thus my picture on the right versus the normal synovium on the left. So the idea for us as clinicians is to get the patient like this on the left, because we can make a huge difference than if we get them like here, which is obviously a lot tougher to treat, right? And you can kind of see the intermediary one right here. What I like about this one is it shows us the two most common joints in RA, which is the second and third MCP. What I like about this one is it's kind of early. You know, rheumatoid is we always think about it from school. Symmetric, systemic, polyarticular. Doesn't have to be in the beginning. Could be one ankle, right? It doesn't have to be your hands, both hands. It could start asymmetrically for a year or so until it really progresses. In fact, 5% of people with RA, it actually starts in their feet. So, you know, some people only have foot pain. So when you have that inflammatory patient, and I'll talk about that in a minute, always consider that possibility. And over this slide, you appreciate the deformity, but the other thing you'll appreciate is that there's a lot of black in that x-ray because the bones are very thin. So rheumatoid is definitely a cause of osteoporosis, especially near the joint margins like that. This slide I like because it shows us the joints that get affected in RA. Any joint that has synovial lining and synovial fluid is fair game. Feet, ankles, knees, hands, wrists, elbows, shoulders, jaw, and even the back of the neck. So back of the neck. So what does that mean? Well, here's a potential danger point for all of us, actually, if you see patients clinically, or especially if you work in a hospital system or an ER. I wrote it as a case to be fun, but we'll just go through it real quick. 62-year-old female, 25-year history of RA. She needs preoperative clearance for surgery that will require general anesthesia and intubation. On exam, she's got deforming arthritis, takes methotrexate, 20 milligrams a week with folic acid. She has minimal morning stiffness and has minimal pain. So the minimal morning stiffness and minimal pain just kind of lets you know she's probably fairly well controlled. Her hands show severe deformity without tenderness. So this is the one that has chronic disease that's been there a long time. And you may have to clear her for surgery. Now, what could you do? Call rheumatology to come in and clear her, right? You can't get a rheumatologist to come in the hospital. You guys know that, right? So that's not going to happen, right? So whole nother subject. But so you check your labs, you make sure she's cleared, but there's something else you have to be concerned about here, right? Long-standing disease, and it's someone who's going to have manipulation of that neck in any way, shape, or form. You have to be aware of something, and that is, right? Very good. So I'm fighting laryngitis. I apologize. So what happens is that in RA, what happens is, remember, think back to, and this is great because we're all DOs, we all know this really well. Think back to the upper cervical spine. The odontid process sticks up from C2 and it attaches to the back of C1, posterior part of the anterior arch, right? Held in place by cruciate ligaments. Those ligaments actually, in any inflammatory arthritis that's systemic, even in ankylosing spondylitis and psoriatics, those ligaments get worn away. So now C1 and C2 are not locked very closely to each other anymore. Now they're very loose, very loose. And in a patient who has long-standing disease, and you may get a hint, maybe they click back here, maybe they have pain back here, but you may not. But in a patient with long-standing disease, they separate out. If they undergo intubation very quickly, or even for people that like to manipulate, you have to be careful with those people in that area. I always say, safe rule of thumb in RA, don't touch the upper cervical, just soft tissue it. That's just my own opinion. Some of you have different comfort zones with it than I do, but that's what I would do. But because you don't know. But what you do need to do in a case like this is a flexion extension film of the neck, because that's going to force that separation. Less than 5 is normal. Greater than 10 has to be treated, has to be evaluated. Don't clear anybody greater than 10. 5 to 10, you're in that gray zone. You may want to get a better test, maybe MRI, or at least let the surgeon and the anesthesiologist know. Also, deceleration, acceleration injuries, same thing. Somebody comes in after a motor vehicle accident, may have, what's that sign? Lermit sign, right? Lermit sign, you bend your chin down, you get electric shocks down your back. That sign they see in MS and myelopathic disorders. That could be a sign of it. Or pain coming from that area. Always keep that in mind. This I like, we'll do this real quickly, all the extra articular manifestations of RA. It's not just a joint disease, right? Inflammatory disease loves the joints, right? That's why we have rheumatology. Loves the skin, loves the lung, loves the eyes, right? Most common complaint we see in the eye, and you'll see this in your patients, dry eye, dry mouth, right? You don't have to have Sjogren's antibodies to have Sicca complex. Sicca complex is dry eyes, dry mouth. Very common in autoimmune disease. So you see that. In some cases, you see horrific inflammatory eye disease as well. Bad cases of scleritis we see. Lung. We talked about lung a little bit. This is really at resident level, but remember, rheumatoid pleural effusions are unique because they have a very low glucose. You're not going to find many things that give you a glucose of 10, glucose of 15, glucose of 20 in the pleural space. Pericardial disease, usually not hemodynamically significant. Spleen could be big in a lot of our autoimmune diseases. We see it in RA. We see it in RA when the white count is low and they have a lot of infections, and we call that Felty syndrome. That's usually aggressive disease as well. We don't see as much amyloid anymore because we really treat these patients aggressively. So we don't tend to see as much amyloidosis. Years ago they did, especially in the kidney. But because our treatments are a lot better than they were, we're really seeing less of that. Most of our patients that have active disease are anemic. Chronic disease, anemias are very common. High white counts maybe low white counts, and our platelet counts go up when they get inflamed. They can get carpal tunnel syndrome, very common in rheumatoid, very, very common. And if you think about it, if you're going to start getting inflammation of this wrist, and that median nerve there, that carpal tunnel is not that wide. It doesn't take much to start giving it a little bit of entrapment. And we even see tarsal tunnel in the foot. And then we see lymph nodes like we mentioned. So what I want to do here is just give you a case real quick, how we approach a patient with RA, and I put some stuff in there just to kind of bring us, to level set everybody, and what we're looking for in the patient that has inflammatory disease. And then we'll talk about treatment. So a 55-year-old female comes in the office with complaints about pain in her joints that has worsened over the last 3 months. This is kind of what you would see, right? Considerable morning stiffness in her hands lasting than 60 minutes. Morning stiffness in your joints greater than 20 minutes, always think inflammatory. Morning stiffness in your joints, less than 20 minutes, lean towards non-inflammatory, or someone who's really well controlled. Right? Not 100%, but fairly accurate. Best time of the day is the middle of the day after she starts moving around. My rheumatoids, the worst time of the day for them is when they wake up and after dinner when they stop and they sit and then they have to start moving again. So worst after periods of inactivity, great when they're moving. Exam shows tender MCPs, 2 through 5, tender MTPs when you squeeze the foot, painful range of motion of the elbows and the wrists. So the differential there is pretty big. It could be RA, it could be lupus, it could be Sjogren's, it could be psoriatic, it could be a lot of stuff. But she has no rational Raynaud's, some sicca complaints and fatigue. You think it's inflammatory. You say there's nothing else going on. Maybe RA, symmetric, polyarticular. So what do you want to get? That's the first question. So you want to evaluate this patient for RA. You want to screen this patient for inflammatory disease. So I break it down into 2 simple initial, or actually 3. First is, number 1, you want to look for signs of systemic inflammation. That's it. Just systemic inflammation. You want to screen. SED rates, CRP. That's all you got to do. Remember, SED rates outpatient are tricky because if it sits for 6 hours before you do the test, it loses validity, so they're often a lot lower. So the CRP, which is a direct measurement of inflammation, not indirect like the SED rate, the CRP is direct. CRP is more accurate at giving you a number. Remember also that SED rates and CRPs aren't the same for every disease. CRP and RA may correlate pretty well. CRP and lupus, not a good drug. Not a great test actually. You know, a lot of times not accurate. So you want to look for inflammation, CRP and SED rate. Then you want to look for some serologic evidence that there's some autoimmune process going on. You want to screen. What do you want to screen with? Let's actually go to the next slide. So what do you want to screen with? I would screen with a rheumatoid factor like we were all taught. And anytime you do a rheumatoid factor nowadays, make sure you include a CCP with it. They should always go together. Why? Well, you know why. Rheumatoid factors, there's a lot of things that make them positive. They're not very, unless they're really high, they're not always specific for disease, right? So if you go into a nursing home, do a rheumatoid factor on everybody in the nursing home, 30% of them are going to be positive, whether they have RA or not, right? So you have to, the CCP really helps you there. And then the other thing I would do is I would always do an ANA. Does an ANA, if it's positive, mean you have lupus? No, an ANA just means there's 330 million people in the country, right? There's 30 million people with a positive ANA. So if you're doing primary care or you're going to refer to a rheumatologist and you have a positive ANA, please, the one thing that I don't want you to tell them is you have to go see this doctor because you have lupus. Because they come in and they're totally decompensated because they think they have lupus. And we look at them and we're like, no, this is not lupus. This is fine. This is because of this. So there's a lot of things that do it. But you still should do it because you want supportive diagnosis. You want supportive labs in case your tests are negative and you're looking. Sensitivity for rheumatoid factors is about 70%. Sensitivity for CCP is about 70%. But the specificity for CCP is a lot higher. The sensitivity of RF and CCP together, depends what you read, probably around 86, 88% around there. So it increases your sensitivity to do both of them as well. And your specificity because of the CCP. And then I always do a chemistry and a CBC and a urine because I'm looking for disease. And I always x-ray the joints that hurt them the most. Basically, that's just what I said. There's one other test that's there's a whole bunch of biomarkers which are coming out. And a lot of them are still in the research phase. But there's one, I think that's getting a little more play than others. And I kind of order it once in a while. You might see it. So I just want to tell you what it is. There is a biomarker. It's a chaperone folding protein that you see in the synovium. And it's called it's written as 14.3.3 or 14-33 or 14.33 ETA. And it's a test that, when positive, is very significant for RA. So, and what we do is, if the rheumatoid factor is negative and the CCP is negative, and we really think they still might have it, we can give them a diagnosis of seronegative RA, but I do that test as well to increase my sensitivity. And that sensitivity for active RA will take you from 88 to about 96%. So it actually does help. There's some other ones coming out too, just to bring them up. MCV, which is citrullinated protein, a different one than the CCP. And there's a process called carbamylation, which is similar to citrullation, which they're working on tests for as well. Look at all those things that give you a positive rheumatoid factor, right? I know you guys know this, and I don't want to, to be redundant, but there's a lot of stuff there, right? In particular, endocarditis, right? Joint pain, sick, not well. mono common, hepatitis C. Oh my God, we don't see as much active hep C now as we used to. But 15 years ago, we saw so much hep C that was rheumatoid factor positive. Interstitial fibrosis, another one, and even sarcoid. We talked about the SED rate, talked about the CRP. There's something else I want to mention that we do. And it's great to have a test that tells you how active the disease is, right? But they're not 100% reliable. And you guys know this. How many times have you seen somebody that you thought had active inflammation and your SED rate or your CRP is normal? It just doesn't fit. So this is difficult, makes it difficult in the office, and it's also difficult when you're doing studies. So what they did was they came up with an idea. Why don't we do a functional index? Why don't we bring in a component of patient function into this, not just rely on one lab test? So we have a whole different set of functional disease activity measures that we do. There's one called the CDI, Rapid 3. You don't have to do these. You don't have to know them. I just want you to know what we do sometimes. And the CDI is correlated to be as helpful and as accurate as a SED rate or a CRP, and I could do a CDI in probably 20 seconds to 30 seconds. All it is how many joints are swollen, how many joints are tender. On a scale of 1 to 10, Mr. Patient, how do you feel in the last 3 weeks, and my global assessment as well. And that number, when given as a value, actually correlates pretty well. So those are things that we do. If you ever see those terms, or you see our notes, and you see CDI this, Rapid 3 this, you know what we're referring to. I use this. We're not going to spend a lot of time on this. These are all the things that raise your SED rate and raise your CRP other than RA and other than inflammatory rheumatic disease. Appreciate the fact that there's a lot there. I will tell you that SED rates, because remember, they're indirect. So SED rates are indirect. They're not direct measurements. So and it measures how fast the red cells sediment in an hour in a tube. How many millimeters do they travel in an hour? So if your red cells are different, your SED rate's going to be different. In fact, if you're anemic, your SED rates are high, unless you have sickle cell. That's the one thing that'll give you commonly lower SED rates. And anything that causes proteins to be higher in the body, if I think about it as terms of maybe making the cell heavier, what it actually does is changes the charges on the cell, and they fall faster, like myeloma, like pregnancy, like women, right, gender, things like that will raise it. Older people have higher SED rates. So real quick story, I'll let you go. SED rate goes up with age and is higher in women. A woman's age plus 10 divided by 2 is what her SED rate should be, right? So 80-year-old female comes in, she's got chronic headaches, and there's panic because the SED rate is 40, because it's off the chart. The lab says the SED rate shouldn't be any higher than 28 or 32, and she's 40. But really, if she's 80, plus 10, it's 90, divided by 2, 45, she really has, relatively normal SED rate. 100% accurate. If she had jaw claudication and had aches and pains everywhere, would I believe only that? No, you do it clinically, of course. But there's a difference, right? So woman's age plus 10 divided by 2. In a male, it's his age divided by 2. So just a good little rule of thumb there. All right, let's talk about the meds real quick. Am I doing on time, okay? Good. So what do we know? We know that if we treat early, we make a huge difference in RA, right? If we treat early, we make a huge difference. So what is that? So look at this slide right here, actually. If you start treatment here, this axis here is progression. So if I start treatment here, 5 years later, look at how low in progression I could be compared to the person that I waited a year or 2 or waited a year, 3, 5. I was a fellow in like the early 90s. We used to use NSAIDs for a year back then before we gave them anything. And a lot of you, I'm sure, were trained that way too. And if we got really brave, we would add like one drug after a year, like something like Plaquenil, because we were worried about the side effects. Now it's so different. But this is where you really make a big difference to the patient. And I like this slide. My problem with this slide is I tend to spend too much time on it, but these are the evolution of our RA drugs, right? First drug really for arthritis, probably the willow bark, right? Willow bark, the bark of the willow tree, right? They knew this in Egypt. If they got if they got the bark and they boiled it and they chewed the bark or ingested it, they actually it has salicylates in it. And that's where the salicylates came from. The first salicylates came from that world. And then it wasn't until the 1900s, early 1900s, that they figured out that they could acetylate it and make it easier to tolerate, easier to take. You know, they work. And if I gave somebody only aspirin for rheumatoid, I could help their inflammation. The problem is I got to give them like 18 to 20 aspirin a day to help the inflammation, right? And aspirin works for pain at 2 pills a day, 2 pills, but it works for inflammation at like 18, and by then you're toxic. I think one of the biggest jumps for us came in the 1950s. In the 1950s, and if you just give me a second to tell you a quick story, the war effort. So 1941, the U.S. enters the war, and the National Research Council is approached by the American military and the government, and they say, look, we need 3 things from you guys, right? It's 1941, we're going into war, and we need 3 things. Number 1, right now, we don't have enough penicillin. We have this drug that works, and we used it in World War I a little bit, and right now, we're giving it to a soldier, we're letting him pee in a jar, we're straining his urine, and giving it to the next guy. So you got to find a way to make us more penicillin. You got to find a way to make this, mass produce this, synthesize this. You got to find a way to help us with this. That was number 1. Number 2, we need a better drug for malaria, right? We have all these guys now. We're involved in the war. We have Japan. We have to have drugs against malaria. And the only drug they had at the time was some version of quinine, so they needed a better version of that for malaria. Number 3, they said that we have proof that the Germans are feeding their pilots, this is going to sound crazy, but it's true, adrenal gland extract. So they're getting like 100 grams of adrenal glands to make 1 gram of adrenal gland extract. And they're giving it to their pilots. And their pilots can fly higher, longer, stay awake longer, and they're giving it to their soldiers. And I'm going to borrow a Marvel term because I'm a complete nerd, I apologize, but they're creating a super soldier, right? So this can't be. You guys have to figure out, and we have to synthesize this. So what happened? All the research went in. What happened by the early 1950s? Penicillin's coming out more and more, right? Hydroxychloroquine hits the shelves, and you get the first cortisone. And the first cortisone done at Mayo is actually great. If you could look it up, I think it's online. If you go on YouTube, you see the patient with rheumatoid just barely getting up these stairs on a stage, you know? And then they give him, I don't know how much steroid they gave him, and that was by the way the real cortisone. The first one that came out was called cortisone. And they gave it to him every day, and they filmed him every day. By the end of the week, the guy just goes up and goes down, and the place is going crazy. Nobody has seen this before. This is like 1953, 55, 56, around there. But what happens? Well, they keep him on it. Great. And then you know what happens after that. I don't have to go any further. But then they realize that, hey, these things have side effects, you know? So, and then but they came out of there. The other great drug that came out of the 1950s, and I'm sorry for this, but I think these are cool stories, was methotrexate. Methotrexate was the first chemotherapy ever created. It was methotrexate. And they gave it to a child that had ALL, acute lymphocytic leukemia. And it was up in Boston. Kid's first name was Jimmy. Nobody lived back then if you had ALL. And Jimmy lived I think 10 months or a year, longer than anyone ever expected. So the doctor was Dana-Farber. The child was Jimmy. If you're a Boston fan, which I'm not, I'm a Yankee fan, but if you're a Boston fan, the Jimmy Fund is from that child. That child created such an emotional outpouring in Boston that they created the Jimmy Fund. So anyway, and then in the 1950s, when they saw methotrexate being used for chemo, somebody had the idea to use it in RA. And then the other doctors said, what are you, crazy? You're going to use a drug like methotrexate in such a benign disease like rheumatoid? You can't use that. So it sat on the shelf until 1982 when a Harvard researcher, Mike Weinblatt, did a study and it said, hey, no, this stuff is good in low dosages. And then the other one I think worth mentioning is about 1998, etanercept hit the shelves. That was the first biologic as we know today. And nowadays we have a lot more options. So we know that damage occurs early. We want to move quick. We want you to treat it when it looks like this, not when it looks like this. So then you have all the nodules, the muscle atrophy, the deformity, the chronic pannus formation. Really a tough hand. By the way, if you have a patient on methotrexate and has nodules like that, as good of a drug as methotrexate is, it worsens your nodules. So if a lot of people have a comfort zone with methotrexate, and I think it's great. If you have them on a low dose, even 3 a week, 4 a week, and their nodules are getting worse, it's the drug. So stop the drug, switch them to something else, right? The instinct is the nodules are worse. Let me give them more methotrexate to treat the nodules. No, it's the other way. The nodules get worse. And in some cases, the inflammation is so bad, like we talked about before, it can affect other organs, but it can even give you a vasculitis. And it's usually a small vessel vasculitis. Small vessel meaning it likes the vessels in the skin, and you get breakdown like this. So this one I would treat this with steroids. Obviously good wound care, but then steroids as well. And some of the stronger drugs that we use. We talk about our therapies, and I'll go over these quickly. Well, we all know that you can use NSAIDs. We tend to use NSAIDs now as needed. And maybe in the beginning you can give them that when you're looking for your labs, but always try to make them as needed. Minimize the risk by minimizing the NSAIDs. Steroids we know are great, but you really don't want to use them chronically. Even 5 milligrams a day in rheumatoids is not good. So we try to do that. Is it easy to do that? No, because sometimes the coverage isn't there for the drugs, right? So when I was a fellow, I could get probably 100 methotrexate for $15, $20. Now it's got hundreds of dollars for 100. So it's expensive. So some people have to take a little bit of prednisone to help. But after that, you really want to go to your DMARDs. And I'll go over the DMARDs very quickly, very, very quickly. I'm not going to bore you with that. And I want to show you where our biologics work and some of the other medicines that we have out there before we get to questions. So you guys all kind of chuckled before when I said steroids. You know what happens? I like this slide. This is really, you guys are beyond this slide. It's not for you, but it's just kind of cool to see all the side effects that steroids can cause, right? So what are our 4 DMARDs now that we use in rheumatology? Methotrexate, sulfasalazine, plaquenil, leflunomide. Methotrexate, I'm not going to bore you with this, I'm sorry, some important things to mention. Methotrexate given once a week. We don't use it at chemo dosages, we use it at anti-inflammatory dosages, 4 pills a week, up to 10 pills a week, that's it. Safe, works well, works on cell turnover. Anything that works on cell turnover has like the same kind of nuisance side effects, hair loss sometimes, stomatitis sometimes, oral ulcers, right? But it can elevate transaminases, you have to know that. And the way we get around that is we give them folic acid, which replaces the folic acid because it's a folic acid antagonist, and it helps keep the liver enzymes down. So if you have a patient on methotrexate, make sure they're taking folic acid with it. They have to take folic acid with it, have to. It's teratogenic. Be really careful in women of childbearing age. They have to stop it for, the rule is 3 months. Technically, I'll tell you, it's probably a month is fine, but tell everybody 3 months. It's a great drug. It also increases something called adenosine, which is a pretty good anti-inflammatory, and we think that's how it has its anti-inflammatory effect. Rheumatologists love methotrexate. Patients hate it. Makes them feel like crap, right? So you may actually encounter this, and this is why I have this slide here. So, doc, I take my methotrexate on Monday. I'm feeling good, my joints are better, but I feel horrible Monday. I've got the blahs, I'm tired, I'm achy, I'm nauseous. I want to stop the drug. Well, methotrexate metabolites can actually bind to NMDA receptors in the central nervous system and make them feel crummy. How can we get around that? It sounds crazy, but we give them dextromethorphan. So Mucinex DM. The DM binds to that and helps prevent the binding of the metabolite to the NMDA receptor. So I tell them, look, I know you're taking methotrexate on Monday. Sunday night, take a Mucinex DM. Monday morning, take one, and Monday night, take one. And see if that doesn't help. Does it help 100% of the time? No, I wish I could tell you it did. But it works a lot of the time. So I think it's worth a try rather than stop the drug. That's the dihydrofolate reductase that it inhibits. Why do I put that slide in here? Because Bactrim, trimethoprim sulfamethoxazole, is a commonly used antibiotic that we all use a lot. At least I used to use it a lot. And it is a folic acid antagonist. And it has synergistic antagonistic effects with methotrexate. So if you treat somebody with a UTI for 3 days and they're on methotrexate, I don't think you're going to have a problem. But if you treat them like a chronic sinusitis and you have them on Bactrim BID for 14 days or something like that, you're going to get yourself in trouble with bone marrow suppression. So don't use the drugs together. We see that a lot. We see the people that have been on it, and first thing I do is check the CBC. I've seen one case where the white count went down, so just keep that in mind. They shouldn't be used together. No pregnancy, alcohol. I tell them 2 drinks a week. Now, I tell them 2 drinks a week, knowing that it's probably going to be more than that. In Europe, the rules are a little more liberal, and in Europe, they have a little more transaminase elevation. So, it's toxic on the liver, like a lot of our drugs. Alcohol's toxic on the liver. They work together. They can create fibrosis. So, important about that is that what's one thing. Everybody's interpretation of a drink is different, right? My glasses of wine got bigger as I got older. I don't know about you guys, but okay. But it's funny, my European patients, like I have a lot of Portuguese patients, and I'll say, you don't drink alcohol at all? No, not at all. Nothing? Not even a glass of wine at dinner? Oh, of course. So, okay. We follow transaminases, especially if you're worried about that. But methotrexate is one of those drugs that can cause fibrosis, can cause cirrhosis without elevating your transaminases. So it happens. It's one of those drugs that can do that. So what do we do then? I follow the albumin. So if you're doing primary care and you see your patient's albumin is dropping and they're on methotrexate, that's the sign that they may be getting liver toxicity. That's the sign when you have to send that forward or stop the drug on your own. But that's a sign of liver damage or liver toxicity. If you stop it, it can reverse. And it worsens your nodules. We talked about that. Plaquenil is a little bit more story about Plaquenil, but we can skip that for another day. The Duchess of Chincona was the first woman to get this ground up quinine, and it became used for the first time through her. There was a Jesuit priest that brought it to Europe, and it became known as Jesuit's powder. I like the World War II story better, though. And Plaquenil is one of the safest drugs that we have. It's a phenomenal medication for lupus. It's like vitamin H. Everybody with lupus should be on it. It's an okay drug for RA, but it's a drug that everybody has to have, and it's good for primary. When you're out of your comfort zone with methotrexate or one of these other drugs, and you call the rheumatologist to get the patient in, and the next visit is like 4 months away, and you're like, what am I going to do with this patient? This patient has a high rheumatoid factor, high CCP. You want to start them on something, you can start them on Plaquenil. There's really no major side effects with the drug. It works very well. It's very safe. The side effects are retinal toxicity years later, not early on. You could put them on 1 in the morning, move them to 2 at the end of the week or the next week, and within a month they'll start to feel better. Because most of our drugs take a long time to work. They take at least a month. So it's a super safe medication. It's not immunosuppressive. If they have a chronic viral infection, it's not going to raise the levels. It doesn't, I'm sorry, my opinion only, it doesn't work in COVID. It does not cause QT interval prolongation unless they're like really, really, really sick. And then if you want to raise the question, because they're on a lot of other meds, I'll give you that. Chloroquine causes QT prolongation. Hydroxychloroquine really doesn't. They used to say to us when COVID first came out, well, how often do you guys do EKGs? We were like, what? We don't do EKGs at all, because it's just never been shown to show it. And it's not immunosuppressive. If you have a patient with G6PD, it actually might cause a hemolytic crisis too. I don't screen them for that. Most rheumatologists do not. And we check their eyes, baseline, and honestly, you can do it 5 years later. The problem with retinal toxicity is if you give them too big of a dose for too long, it deposits in the back of the retina, and it's dose dependent and duration dependent. So I've seen one bad case in 28 years, 27 years, and it's actually 2 years ago. And it was a typical lupus patient, non-compliant. I wouldn't see her for a year at a time, then she'd come back and she was getting her Plaquenil somewhere else. And finally, after a couple of years, I said, you gotta go to the eye doctor. And she went to the eye doctor, and the eye doctor calls me up, and he says, look, that's her on the right. He said, she's got classic bullseye retinopathy. And what happens is that if you use too big of a dose, and the magic number for us is 5 milligrams per kg, not to bore you with numbers, but I want to just show you the slide. If you go higher on the dose for a longer period of time, that's the green line, That's the increased risk of retinal toxicity. If you go lower on the dose, you can see the dotted blue line at the bottom there, a lot much lower risk. So we always try to get our Plaquenil dose down. Sulfasalazine, also very safe in pregnancy. We use it a little bit as an add-on medication. You got to watch the liver and the bone marrow. Leflunomide, what I think you need to know about this is that this is a medicine that's a little bit unique in that it's very significantly highly believed to be teratogenic, right? And if you stop taking the medicine as a female, you can't get pregnant for 2 years. Right, there's the trick, right? 2 years, unless it's washed out. So I don't use it in women of childbearing years. Why? If I have a good relationship with my patient, I'm fine. But let's say she changes her insurance and she goes to somebody else. And then that person forgets to have that conversation with her. You know what I mean? I don't trust that part of the system. So if you're going to use it in a woman of childbearing years, or you know one of your patients wants to get pregnant, they have that conversation with you, leflunomide has to be washed out. How do we wash it out? Cholestyramine. Remember the old cholesterol bile acid binding drug, cholestyramine? Use it for IBS too. I think cholestyramine twice a day for 11 days, and then you measure the metabolites, and then they can get pregnant. But 2 years is a long time, so you've got to be really careful with that. This slide I really like. And this slide is good because on the left here, and what I'm doing to show you where our meds work. On the left, you see that T-cell interaction I talked about, and the T-cell hands the ball off to everybody else. And then the production is of these inflammatory mediators here, right? And then we have inflammation. So we can actually target those inflammatory mediators. And we do. We have drugs that go right for the TNF, or maybe for the TNF receptor, right? Or IL-1, or the IL-1 receptor, right? We have monoclonal antibodies or receptor proteins. Enbrel, etanercept is Enbrel, adalimumab is Humira, right? You guys get the idea. Or we can actually target the cells right here. So particularly here, we go for the B cell. Before it happens, we're working a little bit more upstream. Rituximab. Rituximab actually is a monoclonal antibody against a CD20 protein on an immature B cell, premature B cell, before it differentiates out. So it'll knock those B cells down. Really superb drug in lymphoma, in the lymphoma world. That's where it came from. And we use it in RA. Great drug for rheumatoid, bad drug for COVID. So bad drug for COVID. Most of our medications in rheumatology, I'll talk about this at the end a little bit, most of them did not really have significantly adverse events on adverse outcomes with COVID. This one does. This is a bad boy for us in COVID. And the other one that's bad for us in COVID, in terms of biologics, is the one that works right here, the one that inhibits that T-cell interaction. That's called abatacept. The trade name for that is Orencia. So people that take these two medicines, 3 years ago, I would have said to you, they're my two favorite drugs. They work great. They're safe. They work really well. They're good for patients. But COVID changed that a lot. It really made it difficult for us in rheumatology. The TNFs and everything else didn't. Just different ways that we make antibodies, different effects of IL-6, which we don't have to go on that. A close-up view of our T-cell inhibitor, we don't have to do that. So yeah, so one more thing, I want to go back and show you one thing. See right here where we have joint inflammation and destruction? That's because the TNF, the IL-1, the IL-6, the antibodies, they actually go to the cell and they go to the inflammatory cell and they trigger the inflammatory cell to create inflammation. Change the DNA in the cell to really start producing inflammatory mediators, right? So what we could do, we actually have medications that go to right where that inflammatory mediator is attaching to the cell. So the TNF that you saw from the last slide comes over and it finds its receptor, and through a process, it tells the nucleus to make inflammation, and we can stop that process. Those are the JAK inhibitors. So you may see people on Xeljanz or Rinvoq. I'm using brand names, which I don't like to do, but or Olumiant, which is, Olumiant, Rinvoq, or Xeljanz are the three JAKs out there. Tofacitinib, upadacitinib, and baricitinib. What do you need to know about that at the primary care level? They have obviously liver, bone marrow, like anything else. They have a significantly greater risk of zoster. So 2% of the general population gets zoster in a year. 4% of people on a TNF get it. Like 9% of people on a JAK inhibitor can get it. 7 to 9% can get it. So I try to make sure that they're vaccinated for zoster before. If you do hospital work, baricitinib too, because They use that in treating COVID. So what are the concerns that we have? No live vaccines. You have a patient on one of my drugs and they want to go to Southeast Asia and they need a yellow fever vaccine. No live vaccines. You cannot get a live vaccine on these medicines. You want a live vaccine, hold it for a month, then get the vaccine, and you can restart it 2 weeks later. No live vaccines. Inactivated vaccines, fine, not a problem. What is the question, though? The question is the medicine preventing the vaccine from working? That's the question, right? But they're not going to hurt the patient. Live vaccines will hurt the patient. Inactive vaccines will not. Make sure there's no TB. We know that. Everybody gets TB tested for these things. But make sure there's also no non-tuberculous mycobacteria. MAI in the lung, difficult to eradicate anyway. That's going to make that worse. If they have a chronic fungal infection, of course, you're not going to use it. Make sure there's no prior history of lymphoproliferative disorders or even a question about there may being one. Don't use it. Make sure they're not on it. So one of my patients on a drug comes in and they got a lymph node and nobody knows why. Stop the drug. If you can't get a hold of the room, stop the drug. You know what I mean? Heart failure, we don't use them. Multiple sclerosis and demyelinating diseases, we don't use them. And one that I think is interesting, we all know about TB, but BCG is different, right? Attenuated Mycobacterium bovis, right? If they're going to get intravesicular BCG for bladder cancer and they're on a biologic, contraindicated. Can't have them on the biologic if they're going to get intravesicular BCG. So if you're working as a hospitalist or it's your patient or your regular patient and you're going to clear them for bladder intravesicular BCG and they're on a biologic, stop the biologic. Or if there's any question about whether that biologic does it, consult a rheumatologist. But that's another danger point for you. Vaccines. So what do we do? So I tell patients, it's kind of okay with the TNFs, but across the board, if you tell your patient, look, you're going to get your vaccine on July 1st, well, this is true for flu vaccine, and this is true for COVID vaccine. You're going to get your vaccine July 1st, just hold it the next dose. You're taking methotrexate once a week. I want you to hold the methotrexate the week after the vaccine, not before, after. Why? Because I want the vaccine to work better. And methotrexate may slow down that antibody response a little bit. Methotrexate in high dosages might have affected COVID a bit in some cases, some of our other drugs too that I didn't mention because they're not part of this lecture, but you want to hold it the week after. You'd never be faulted for that. When they studied it in the flu vaccine, they held it for 2 weeks with flu vaccine. They measured 2 cohorts. The one that had the methotrexate held had higher responses to the flu vaccine than the people that stayed on it. And there was no difference in how they felt a month later. No difference in outcomes. So it's safe. You can do that. Surgery. You're pretty safe holding a dose of medication a week before. You want to hold 2 weeks before, that's fine. Our literature says, like for joint replacement, just keep them on the DMARDs. Methotrexate, leflunomide plaque, just keep them on it. Don't even stop it. So it's funny though, you say to the patient, no, don't even stop it, stay on it. Then you're going to get a call from the surgeon. No, we have to stop it. So I say, okay, we have to treat everybody around us, not only the patient sometimes, so just stop the medication. So, but once the stitches are on, you can put them back. Holding it for a dose is usually good. And then our thing about COVID, which I mentioned already, rituximab and abatacept. So if your patients have RA and they're on our drugs and they get COVID and they call you and they're on one of these biologics, we try to get them something. There's a brand new drug out now, and I won't beat this up. It's called Evusheld. There was a New England Journal article this past week, and it's one of these crazy expensive drugs. It's a long-acting drug. It's 2 monoclonal antibodies. I can't find it. I can't get it for my patients. We're trying to get it. It's so limited in distribution. But there's other medications that we use. We just want to make sure that they're followed. We want to make sure that, depending on the medication, they do have a risk for adverse outcome. I think I'm done. That's the study about flu vaccine. Good. I know there was a lot in an hour, and I'm sorry, but I try to cover a lot of ground for you. And thanks. Any questions? Any questions about anything? Any questions about non-rheumatoid stuff? Giant cell lupus, anything? Yes, Carolyn.
Non-medical action. Your history of medicine, where did you learn it?
So some of it is from anecdotes. Some of it is from reading. Most of it is from reading, actually. There is something, though, I'm going to plug this for this guy. He's a Mayo Clinic rheumatologist. His name is Adam J. Brown. And he has a whole list of history of medicine podcast, which I absolutely love. And there's a whole bunch of other stories, and it just makes it a lot more fun to, when you're using this stuff all the time, to hear the history behind it. So, I did cheat with the podcast, if that means anything. Some of it. Yes, Paul?
Hi, Mike. Any thoughts of screening with CCP antibodies for young asymptomatic people in the general population?
Oh, it's a great question. Yeah, so any thoughts about screening with CCP? And I'll tell you that I would not, and I'll tell you why. Because when sometimes we wind up with a CCP positive patient that comes to us, and there's no symptoms at all. It just happened that maybe the person had a pain, whatever, but there's nothing. Maybe the pain came and went. And we call this actually preclinical RA. There's actually a term that we have called preclinical RA. So is there any value in treating preclinical RA? I've got a CCP that should be less than 20. It's 100. I've got a rheumatoid factor that should be less than 15. It's 40. But I have nothing. No lung, no symptoms. Do I treat? Is there any value in treating? And the data right now says don't treat. So I look at it. Remember, like with migraine medicines, you don't use the migraine medicine before, you wait till the headache starts, right? That's still the same, right? You wait till it starts, then they work better. Same thing true for RA. You watch them, you monitor them, and if you see it starting to take off, then you intervene, and then you put them on something. But there's no value in, and they've studied rituximab, and they've studied hydroxychloroquine, and neither one of them showed a benefit. Yes, Doc?
So I had seen a patient several years ago, needed to establish a primary, and I wound up diagnosing her with RA. Several months later, she came in with a cough, almost like an ACE inhibitor cough. And I had her CGI, pulmonary, went around, nothing. And when I sat down and went over that natural history, it started shortly after the methotrexate.
Yeah.
And so I stopped it, and the cough miraculously went away. No one had ever seen that before. I was just curious, is that something that you see short of actual interstitial lung disease and things that do turn up on workups?
So methotrexate, we all remember this from school, in big dosages can cause interstitial lung disease. But methotrexate in the lower dosages in our patient population does not, the data says it does not worsen interstitial lung disease. So if I have a little bit of ILD, I'll use it anyway, and I'm comfortable doing that. But here's the important thing to remember. Very rarely, I've seen 3 cases in 28 years, very rarely people will have a hypersensitivity reaction to methotrexate. And that's a lot more acute than that. They're sick. They're in the hospital. There's infiltrates in the lung. They're sick. Everyone's thinking, viral pneumonia. They're thinking PCP. It's got that kind of a picture, and it's the methotrexate. In that case, we hold it. We support them, and because we have so many choices now, we don't put them back on it. When I was a fellow in the early 90s, we put them back on it, and it would usually happen again. But one thing, Doc, and to this story, it actually happens within 6 months of starting the medication. So most commonly, you can have it happen later, but usually what happens within 6 months. So good pickup on your part, good clinical decision. You might have actually helped her from getting to that point, which is great.
Thank you.
You're welcome. Any other questions? Thanks again, guys. Appreciate it. Thank you.
Appreciate it. Maybe I'll see you around town. All right. Thank you, Dr. Guma.